So this morning I'm going to talk to you just really briefly about chemotherapy safety and chemotherapy policies here at UW Health. So here's our objectives for this morning. So just kind of level setting again. A medication error is any error that occurs in the med use process, and that can be anything from ordering to incorrect patient information, such as pounds entered as kilograms. It can be staff competency, drug ordering again. So anywhere in the drug medication use process. So how do medication errors happen? You guys have all seen this, the Swiss cheese model. Some holes are due to active failures and other holes are just due to latent conditions. But when they all line up, the errors can get through to the patient and can, of course, really affect them. We have multiple layers of kind of defense. We have chemotherapy ordered electronically. We have standard core treatment plans that are vetted by multiple disciplines. We have chemo competency for RNs, pharmacists. The fellows go through chemo competency before they prescribe chemo, the APPs. And then we have independent double checks throughout. Despite this, again, the holes can line up and really affect patient care. We fortunately have not had a serious chemotherapy safety event for quite a while, but we do have them happen, and it's good to kind of remind ourselves of how dangerous this can be, because there is no perfectly safe system. Back in '97, when I was kind of a young oncology pharmacist, they reported adverse events, including medication errors, do increase length of stay, and do increase costs. And then various authors have reported that about half to 2/3 of serious adverse drug events are preventable. The FDA receives more than 100,000 reports every year of medication errors. These are usually the more serious ones. And more than 7 million patients in the United States are impacted by med errors every year. Unfortunately, 10% of hospital errors will be subject, or hospital patients will be subject to some sort of a medication error. Now, specifically, chemotherapy errors can range from incomplete orders to life-threatening errors. And what studies there are, and there are few, show that chemo errors occur at a rate of about 2%. And they occur again at all stages of the medication use process. And oral chemotherapy use seems to be a particular area of growing risk. And part of this is lack of access to patient-specific information by outside pharmacies, and then amount of medication taken per dose, or not as a daily dose to be divided, seems to be the big errors with oral. So why do we focus on chemotherapy safety? Why does Mike Fallon allow us to have time, or ask us to have time in this course for you? So of course, med safety concerns are not unique to any drugs, but there are some special things about oncology. So anti-neoplastic agents, as you are well aware, have the lowest therapeutic index than any other class of medications. And kind of unlike maybe some other medication classes, subtherapeutic doses really can cause significant harm. And in chemotherapy, the dosing interval, and route of administration can vary significantly as a function of the specific tumor type and the stage of the disease, which makes it more difficult then to know if you're giving the right amount, and for the nurses and pharmacists checking the orders to make sure that it's right. And some examples are that a normal dose of methotrexate can range from 10 milligrams to 20,000 milligrams. Total doses and infusion durations of 5-FU vary widely across regimens, even for the same stage of disease. And cytarabine dosing varies widely depending on the indication and the length of the infusion. This is just to show you that ISMP, or Institute for Safe Medication Practices, includes chemotherapy. These are kind of their best practices recommendations. And then Still in some areas, vincristine and other vinca alkaloids are being administered by the intrathecal route, which of course is fatal. Dosing of oral methotrexate continues to be a problem, and so forth. So just so you know that oncology is specifically included in these like 12 national best practices. Here are some selected chemotherapy medication errors and outcomes. I'm not going to read them to you, but as you can see, many of these cause patient death or at least serious patient harm. So the Dana-Farber story, I was out in New York working as an oncology pharmacist when this happened. I'd been doing it for about, I guess, 3 or 4 years when it happened. And this is when chemotherapy safety really started to be looked at more scientifically and really trying to describe what we could do to make things better. So basically, this was in Dana-Farber, so a big cancer center. And this is back when we did auto transplants for breast cancer, which of course didn't work. But Betsy Lehman, who was actually a health columnist, and another Maureen Bateman, who was a teacher, were prescribed and received 4 times the intended dose of cyclophosphamide for their auto transplant. And instead of prescribing the daily dose to be given on each of the 4 days of the cycle, the combined 4-day dose was given on each day. So this was written by a fellow. This is back when we used to write orders. 25 medical staff were involved, and they were all very experienced, very good medical staff. And not one noticed the problem until weeks later when a research coordinator who was kind of finishing up the documentation noticed it. They actually were able to support the patients through the neutropenia. Unfortunately, Betsy Lehman died of cardiac issues, and then Maureen Bateman suffered permanent heart damage from it and then subsequently died of her original cancer. Here's another horrible story. So this was a young patient, 2-year-old Emily Jerry, the Rainbow Babies story. This was a preparation error for this child who, and it was actually, they gave 23.4% sodium chloride with the etoposide versus the normal 0.9% sodium chloride with etoposide. It resulted in this child's death. So actually, this pharmacist went to jail over this. He has since been released from jail and now works for medication safety, actually speaks with the father of this child. If you can ever hear him speak, it is pretty, the father of the child and this pharmacist, it is pretty impactful. So here at UW, we've had 4 serious medication errors since 2010, with 2 ICU stays, 1 acute kidney injury. We did a ton of work on this. Mike Fallon is quite the expert on it and is working on publishing his work. But we actually came up with a high-dose methotrexate clinical practice guideline. We did a root cause analysis. We did several root cause analysis. We have all kinds of safeguards around it, but I guess a couple things to take away from this: errors do happen here that can hurt patients, and working together can really improve the process. So there are many potential causes of chemotherapy medication errors. As we talked about, the total course or cycle doses given daily, lack of pertinent healthcare information. I'm not going to read all of these to you. We do use a lot of abbreviations, right? Dose adjusted EPOC, HIDAC, so CHOP. So to us, they mean a lot, but to a new practitioner, they may not need as much. A lot of these errors have improved since CPOE. So as we've had, chemotherapy electronically ordered, we have been able to prevent a lot of errors. We've just seen kind of some new errors. And just so everyone is aware, here at UW, verbal orders for chemotherapy are prohibited. The only verbal order you can give is to stop the chemo. So we're going to talk about policy 6.1.3 here. This is how we've addressed intrathecal chemotherapy safety. We do have a very specific policy here on what can be given intrathecally, so only these drugs, so methotrexate, cytarabine, and cytarabine liposomal, which is still in the policy but not available anymore. So basically, methotrexate and cytarabine are the only chemo agents that can be administered intrathecally at UW Health. They show what drugs can be given as flushes. As I spoke about, inadvertent intrathecal administration of drugs such as vincristine and bortezomib is still being reported in the literature. It's universally fatal. We did have a UW Health error here in 1999, but it took us until 2010 to give vincristine as a small infusion bag. So what happens is that the vincristine, when it's given IV push, which is how it was given for years, looks very similar to a lot of the intrathecal drugs that we give. And vincristine is given at the same time in a lot of leukemia protocols as intrathecal drugs. So here, the vincristine was handed to the physician who was going to do the intrathecal chemo. The physician didn't realize it was the vincristine and not the cytarabine, and started to administer it, recognized what he had done, pulled back. This patient here at UW was actually one of the few ever that survived it because they didn't give much. They pulled it back. They did a continuous lactated ringers infusion in the TLC. The patient was a quadriplegic because of this error. And so intrathecal chemo and any changes to this policy are taken very seriously by our legal department, as it was the largest settlement ever. So also in this policy, any intrathecal administration of a drug must be preceded by a timeout. So ensure that you have the right patient, right drug. So as we've moved to electronic prescribing, there are still problems and kind of unique problems. So incorrect data entry about the patient, an error in electronic build can still slip through, system designs, workflows outside of the electronic build, kind of trying to go around the build, and then confusing chemotherapy treatment plan option presentation. So if you've ever tried to look up a chemotherapy treatment plan, which I'm sure many of you have, it can be hard to figure out which one you want to use. Also, we've noted prescriber issues, so new practitioners or trainees may not learn how to write chemotherapy orders due to an overdependence on technology. We gave a quiz to fellows about 2 or 3 years after we went live with Beacon. Just knowing the doses we found was not something that a lot of the fellows did anymore because it's all available electronically. So figuring out how to train people and then quality assurance has been important. There's a tendency to view it as a task to complete, get all those red stop signs to go away, rather than as a tool to safely prescribe chemotherapy. And then we have seen copy and paste issues within the treatment plan. We once had bevacizumab inadvertently put through the whole plan, every day of a day 1, 8, 15 out of 21. So that was a problem. Just really briefly, the medication event reporting system that we use here is called HERO. So it's healthcare event reporting online. If you go into UConnect, you can find it easily. I encourage you to submit reports. The goal is to report medication errors. This is also how we report adverse drug reactions, near misses, and risky situations in order to improve patient care, promote education, and of course, to comply with accreditation standards. So what it is a way to gather information and develop system-based solutions to events that have occurred. And it's a transparent means of discussing safety solutions for our institution and a forum for identifying opportunities. What it is not is punitive. We support just culture, open idea sharing and discussion. We do not assign blame, and a venue to discuss topics outside of safety-related issues. So what happens when an error is reported? So every event is evaluated by quality department, risk management, a physician, pharmacy, and nursing at a minimum. Queries are made into finding the reasons behind the event. A harm score is assigned. System sources of error. So again, we really focus on how we can prevent the error in the past by looking at systems, and then necessary changes are implemented. And then data is collected and presented at routine intervals. This is what happens when you enter a new event into Hero, how you enter it. This is available by searching Hero in Uconnect. I just wanted to make sure you saw that it's there. It's not probably the most intuitive system that I've ever seen, but they are improving the system on a regular basis. Moving on to chemotherapy-related policies. I wanted to talk to you about two policies today. One is policy 6.1.1, and as you can see here, it's kind of our big chemotherapy processes. If you haven't looked at this policy, I would encourage you to do so. It covers informed consent of chemotherapy, ordering, verification, administration, documentation, and patient and family education. If you have ever any suggestions, you can forward them to me. So this policy covers who can order chemotherapy. So, fellows, once they've been, chemo certified, APPs, once they've gone through the processes that we have developed. So attending physicians. So who can order what? We also take prescribing of chemotherapy for both oncologic and non-oncologic indications. As you guys are very aware, cyclophosphamide, rituximab, a lot of bortezomib, a lot of our chemotherapy drugs may be used for non-oncologic indications. And there was a lot of confusion about, who could order them for non-oncology or non-cancer related indications versus oncologic. So just know that both of those are covered in there. It's a fairly long policy. We also talk about, when nurses and pharmacists verify the order, what they're verifying and who's responsible for what, so that it's very clear. There are multiple related appendices and information available also with this policy. We do have a chemotherapy cutoff time that I want to make sure you're aware of. It is 5 o'clock. So chemotherapy orders need to be signed and the patient's labs resulted and any necessary tests resulted by 5 o'clock in order to receive chemotherapy that day. We do have an Appendix C, which is emergent chemotherapy. So of course we will do emergent chemotherapy when necessary, and we have defined what emergent chemotherapy is. So this is especially a problem on the inpatient service. If you ever have any questions, I encourage you to see our inpatient clinical pharmacists that are on the floor all day. They will help you with this policy and with, what exactly emergent chemotherapy qualifies for exceptions. We only have pharmacists available till 5:30. We have 2 pharmacists here in various areas until 5:30. After that, we have to rely on people doing checks from home because we often don't have pharmacists here just due to our number of FTE. Emergent chemotherapy or the chemotherapy cutoff time, another reason for that is to make sure we have appropriate nursing staff here that physicians or fellows are available for questions or emergent situations. So we do enforce that. We also have what medications are defined as chemo at UW Health. Jason's going to talk to you in a little bit about oral chemotherapy. We have, when we have to do off-unit administration of chemo, what we need to do differently. This is really mostly from a nursing perspective. We have had errors off unit with people who are not familiar with why we need to keep, hydration going, for example. So we have kind of formalized that process. We do have pharmacist chemotherapy competency and training checklists here. And then back when in the pandemic, how we did informed consent. So a really important policy, just so you're aware that it's there. Policy 6.1.3, we've already talked about. This is the intrathecal chemotherapy ordering, administration, and documentation policy. And this is just to assure that we have safe ordering, administration, and documentation of these intrathecal chemotherapy agents. So this policy really clearly spells out what may be prescribed, who can prescribe it, and how it is administered. And I'll take brief questions now before I turn this over to Jason. I don't see anything in the chat. I have to jump off for Hero event review. It's a weekly meeting of serious safety events that I sit on. So I'm going to leave now. If you think of questions, please feel free to contact me at any time. I am definitely around, and you can find me via email. Thanks. I'm going to stop sharing, Jason.
Thanks a lot, Mary. Well, Jason gets his slides up. I'm going to put the class survey in the chat box, and really, if everyone can fill that out, we'd really appreciate it. Every year we work to improve this class, and the feedback we get from you is vital to that process. I have it set up so it really should take less than 3 minutes of your time, so really, really appreciate that. And then finally, after this course, later this week, I'll meet with Sam Lubner on the individuals that are to get chemo certified. And so you'll hear about next steps on the process from him shortly. Let me know if you had any attendance issues, and I'll work with you to rectify those. I'll turn it over to Jason here.
Thanks, Mike, and morning, everybody. Thanks for the invitation to be here. The purpose of kind of the second half of the program this morning is to review, or I guess continue some of the review about some of the pertinent policies that you'll need to be familiar with as it relates to chemotherapy use here at UW Health. So specifically going to talk about chemotherapy council kind of in that avenue. I'll also talk about some of our oral oncolytic workflows, including how those integrate with our specialty pharmacy program at UW Health and prior authorization services. A little bit about me and my background. So my title is Pharmacy Coordinator for Regional Oncology Services. I also serve as Secretary of Chemotherapy Council, which is our oncology P&T committee here. I'm also the program director for our PGY2 oncology residency program. I've been with UW Health since 2012, so a little over 10 years. I trained here and have served in this role since. So nice to see some familiar names. And for those of you I haven't met, I look forward to working with you. So with that, we will launch in. So I'm going to start by covering Chemotherapy Council. So kind of who we are. We are, again, the Oncology P&T Committee at UW Health. So We sit here underneath our kind of larger P&T committee structure that many of you, might be familiar with. You can see there's a lot of other, pertinent subcommittees as well that do impact oncology medication use, but overall, we're really the main committee that the P&T charges with review of any new, chemotherapy product, oncology medication, whether it be for treatment or supportive care. We and our members advise P&T and how those medications should be utilized within UW Health. In terms of our leadership and aims, so we currently have a co-chair leadership model. So we're led by Dr. Natalie Callender on kind of the blood cancer side, as well as by Dr. Dustin Deming on the solid tumor side. And then again, I serve as secretary currently. In terms of membership, we generally have roughly 15 to 18 voting members on the committee, which is represented by a number of physician faculty. We have one APP member, and then we have a pharmacy and nursing representation as well. We've really tried, I think, from the faculty perspective, to maintain kind of a broad representation across the dots, as well as members who have served on our committee for kind of a longer period, as well as blending in some new members as well. So we've really, again, tried to keep it broad from the standpoint of, we're meant to be a peer review group within the Cancer Center. For the fellows on this morning, we do have an experience within the fellowship program, within the HEMOC fellowship program, I should specify, that you'd be rotating through the committee on a quarterly basis. So essentially during that time, you'd be participating as a voting member and really, joining us in kind of all the processes that the committee does during that time. In terms of our aims, so we have 5 aims. First and foremost, we're charged with maintaining the highest level of patient safety at the institution. So Mary kind of touched on a lot of those aspects already, but certainly as we review new chemotherapy products, some of our guidelines, processes, really first and foremost, we want to ensure that we're using chemotherapy safely across the institution. We provide a transparent mechanism for evidence-based peer review. So again, really trying to form a broad peer review structure that, when we're reviewing new therapies or new places in therapies for existing therapies, that we're able to provide that level of peer review for chemotherapy. In addition to safety, we have, of course, we'll evaluate efficacy as well. We do promote uniformity across the center. So obviously we're starting to use, or we do use, some agents and regimens across multiple dots in different settings. So, one of our roles is to ensure that we're doing this in a uniform manner to promote safety, but also kind of standardization in terms of how we do things. And then finally, maximize value. So this is our newest aim. It's been in place for about 3 years. Certainly, I think everyone's aware of the, exponentially increasing costs of cancer care. So we do try to have discussions at the committee level about value defined by outcomes over cost. And, when we have regimens that maybe, the evidence might not support, an incremental improvement, say in efficacy, at what point does that, or how does it really improve value for patients? So there's not a whole lot of, I would say, objective criteria in that aim at this time. However, we at least try to increase those conversations and empower providers to have them with patients. We're governed by policy 6.1.14. So this is our approval of core and patient specific chemotherapy regimen policy. You can look that up on UConnect. It's publicly posted. I think definitely, as Mary mentioned, 6.1.1 is a policy to be really familiar with. I would glance at this policy as well. I think it is something, particularly during fellowship, that you'll be involved with. It does again outline our responsibilities. So I'm going to talk through those here in a little bit more detail, but essentially how we go about our role and meet those aims as we approve both core, standard of care, and patient-specific regimens, as well as we are charged with review of any pertinent oncology guidelines, policies, procedures, order sets, et cetera, as it might relate to oncology populations. So I'm going to talk briefly about a couple of processes. So first is our core process. So we use core kind of synonymously with standard of care. So this is essentially how, again, when a product is available, maybe a new product is approved by the FDA, how we kind of go about our own institutional review to deem it appropriate for use at UW Health and where we're going to use that regimen or that medication. So essentially, this starts really at the provider or the dot level. So essentially, we'll, say in the example of a new FDA approval, we'll generally, reach out to say, if this is something that providers and or the dot, is interested in utilizing. There is a form called the Core Regimen Submission Form. I'll show you where that's at on UConnect. Essentially, we're just looking for indications about where the group sees this being used, which we call place in therapy. So, sometimes that might just be synonymous with how the FDA has approved the medication, but sometimes it might be more nuanced where there's might be competing regimens. And we'd like a little bit of information from the group about the dot thoughts on where it's being used. It's helpful to get maybe a gut check on like how often this, the regimen or medication is being used. So, maybe this is something very rare that we're going to see in one patient per year versus maybe this is a practice changing type of medicine. Really helps us kind of on the operational end, just from a forecasting perspective, to make sure that we can, have it available as it needs to be. And then from a budget perspective as well. So, so basically that information we being pharmacy helps put into what we call a core regimen review template. So essentially, this is just a really brief summary of kind of efficacy and safety, which will ultimately go to the committee for review. That is shared at the dot level. So we really want to ensure that, maybe there's a particular provider within the dot that we're working with most closely to get the core regimen submitted, but we want to ensure that really the dot as a whole has an opportunity to review that and give attestation to get how that's going to be used prior to coming to the committee. It comes to our committee. We meet on a monthly basis, and that will undergo review. If the core of the standard of care is reviewed, that will then go on to kind of our build process. So we have a team within our Center for Clinical Knowledge Management of Beacon analysts that will actually build that regimen within our Epic Beacon platform. That will receive review from nursing as well as pharmacy, and then go on to provider for ultimate approval. And then thereafter can be used in our system. So kind of a lot of steps, and maybe what you would be familiar with kind of from a general formulary review process. I think newish things in this process are, again, just that emphasis on trying to ensure the dot has had opportunity to review, together and give that attestation. And then really, it's helpful to get that information about specifically where we see these therapies being used and kind of trying to forecast, anticipated numbers of patients. So with that, I'll pause. Does anyone have any comments or questions about the standard of care process at all? All right, hearing none. I mean, I think certainly I didn't maybe specify, but we obviously rely heavily on FDA approval and NCCN inclusion, being an NCCN center here. Did want to emphasize that those approvals or endorsements alone does not automatically make a medicine available or a regimen available here. We still have to go through this review process, but certainly having that FDA or NCCN inclusion gives that a lot of backing, and I would say on the whole, generally would be approved. So, well, I'll turn to the patient-specific process. So, we recognize being in a large academic destination center that we're going to have patient populations that are unique, and maybe there's not a standard of care regimen that has been reviewed or is appropriate for the patient. So partially because of that, we do have a patient-specific regimen process. We do have this in place as well, though, to meet our aims of safety, uniformity, efficacy. So again, to ensure that when a provider wants to give a regimen that's not considered standard of care here, that we have a process to get that peer review vetting. So if this occurs, providers can fill out a patient-specific form that's also on UConnect. as well. I can show you where that's located. Essentially, there's just a couple of asks in that form. Obviously, we want some information about the specific regimen that's going to be given. We'd like some justification about, why maybe another standard of care regimen is not appropriate for that patient. Whether it be, very refractory, or maybe it's a new one that we don't have available. There could be kind of a slew of reasons why that would be the case. And then non-formulary medications have to go through that core process, like I just mentioned. So this really is in place to really promote, hopefully, more proactivity in our review. But certainly, we again have this in this patient-specific process in place for kind of some of these outliers. So the provider will send secretary, so currently me, the form. We like about a week buffer. Again, to some of Mary's comments on emergent treatment, certainly we recognize there are going to be cases where patients need to be treated, same day or next day. We, can accommodate that if the patient situation calls for that. I think we just like, if there's something that's less urgent, especially if it's a really involved build, to be submitted earlier, so just to give us the appropriate amount of time from a safety perspective. We'll review that form. It goes out to the committee for review. This is done via an electronic vote, so we don't, we only meet monthly, once a month in person, but the members will vote electronically and review it. And then upon approval, that goes through a build process similar to the cores. I did want to say, we're going to talk very briefly at the end about some insurance pearls, prior authorization pearls. That is a separate process. So there certainly has been occurrences where, say, Chemotherapy Council will back a patient-specific request as clinically appropriate. However, we have maybe a barrier from the insurance side where we're going through some appeal processes. Those are separate processes. So Chemo Council PSR approval does not specifically guarantee the insurance approval and the ability to give it. But certainly, I think there's a lot of payers, particularly on the commercial side, that we can use our committee review as additional backing and justification for why we believe it's an appropriate treatment. So that's our PSR process, kind of in a nutshell. We track these at the committee level. We generally average about 15 of these per month across the center, so really inclusive of all of our sites. So, it's something that does happen with some frequency. We, are always asking ourselves, I think every month, if there's regimens that are coming through with some frequency, does it make sense to push those through the core process or the standard of care process? To try to mitigate some of the the work that would go into this review, but certainly feel strongly that we need it in place just from a safety perspective and to ensure we meet our aims as a committee. So I'll pause again. Are there any questions about or comments about patient-specific process? All right, hearing none, I will just kind of go through a couple of other tidbits about the committee. I mentioned some of the resources. So I've got a link in here that will take you to UConnect. We have our core form, our standard of care form, our patient-specific form that will link out. Again, this is kind of some of the information we're looking for. And then I didn't specifically mention this. We do have a special workflow with our molecular tumor board. So, if our molecular tumor board is endorsing certain regimens, medications based off patients' molecular profiling, we have kind of an abbreviated chemo council process where there's just basically a safety review that would occur just because we kind of defer to the molecular tumor board for some of that efficacy information. We do have a triennial review process. So essentially, at minimum, every 3 years, each of our standard of care protocols will be reviewed at a dot level, just to ensure, again, back to those aims that they're met. So uniformity, standardization, safety, efficacy. Is it a regimen we're still using, or is it kind of no longer standard of care where we should retire, kind of sundown that regimen? There'll be a pharmacist involved with that process that works with your DOT, nursing, and then obviously with the providers as well. And then real briefly, drug shortage management. So could talk probably more at length about this, but essentially, as many of you are aware, unfortunately, drug shortages are a big problem right now, really across many specialties, variety of reasons. Pandemics, natural disasters, legislation, a whole lot of other things. But that we're hopefully going to improve over time. But due to those, we do see those currently. I guess I should say Chemo Council does have a process that helps us kind of manage when these things do come up. So I wanted to just mention that briefly. Fludarabines, just an example that you may have seen that's short right now that we still thankfully have some supply, but that we're managing. Basically, there's an outline of if we did get to the point where we have less than a month of supply on hand, how we would have to go about prioritizing how we would use that therapy. And you can see there's some criteria here. Obviously, these are very difficult conversations. So, legal ethics and other groups would be involved in conjunction with our overall P&T committee and the providers in that specialty. So, these are can be difficult conversations, but unfortunately do have to come up currently every couple of years. So, we do have it spelled out in policy how we do have to address that, and our committee does oversee that kind of from a policy perspective. So. With that, I'll move on to oral oncolytics and some of the processes supporting that. So I don't think it's lost on anyone, kind of the shift we're seeing in cancer care in many of our specialties in terms of the use of, increasing amounts of oral oncolytics in many of the paradigms. Of course, everybody's aware that, this is causing some unique challenges on patients, patients having to take control of their own dosing at home. As well as some cost access issues and monitoring for adverse effects. So we have some processes in place to kind of hopefully help patients with some of those challenges. Really, all of our processes have been guided by best practices that have been kind of sequentially put out by ASCO, ONS, and some other large groups. So there's been a series of gap analyses over the last, I'd say, decade or so, where we've implemented some changes from a policy perspective and a workflow perspective to try to meet those best practices. So I'll just highlight a few of those areas. Mary talked about policy 6.1.1. Again, should be familiar with this. This is kind of our main workhorse chemotherapy processes policy. I think just a couple of call outs for oral oncolytics. We do have that definition of chemotherapy. So that's in Appendix A of that policy. It's key for oral oncolytics. I think there are questions at times in terms of, particularly for some of our hormonal agents, is an agent considered chemotherapy or not, and do those policies apply? So you could always reference that policy. For example, we have taken the approach of, a product like, say, abiraterone, enzalutamide in prostate cancer. We do consider those chemotherapy. So there are repercussions for that, meaning, we require informed consent, and then a lot of these other workflows apply. Versus, say, a product like tamoxifen, we do not consider chemotherapy. So then there's much less kind of restrictions from a workflow perspective. So if you ever have questions about kind of your ability to order or, again, how those workflows apply, you can reference Appendix A of that policy. We also have Appendix B of that policy as well. It's pretty brief, but essentially has just some key callouts as it relates to oral oncolytic use from kind of the overall policy. In terms of ordering, like I mentioned, informed consent must be documented. So if that medication, again, even if it's given oral, if it's considered chemo, we do require informed consent per our standard processes. We do require treatment plans for oral oncolytics as well. So we, of course, have them built for infusional agents. We have them built for hybrids. So if we have an oral oncolytic with infusional therapy, those are built as well. We've always believed that from a safety perspective, oral oncolytics can be just as toxic. So we should have that treatment plan in place, which really helps us ensure that the correct labs and monitoring are applied for that patient. We currently use, I guess, what I'll call a hybrid model for prescribing. So essentially, we, again, require a plan to be applied and then that initial medication to be released out of the plan. In terms of, it can be a little bit agent specific, I think, in terms of, what the required monitoring would be. For some agents that we're, very familiar with and maybe have a more benign side effect profile that maybe you're going to be seeing patients on, eventually maybe a quarterly or even longer basis. I guess imatinib or something like that might come to mind. we do allow refills and those agents to be kind of, reordered just like a general medication would be through the med activity. On the other hand, we have our very toxic agents or potentially agents, say, with a REMS program that would disallow refills. Those products would be built in on kind of a like cycle by cycle monthly basis, and we would ask that they would be reordered out of the plan. So I'd say it's an area we're still discussing. I think we're kind of leaning to continue to order out of the plan as much as possible. But I think the takeaway here is just that, make sure that you have a plan applied at the onset at minimum if you're using oral oncolytic on a patient. We do have a dose modification process in standard note. This applies to infusional therapies as well, but essentially there's a note that we drop within the medical record. It's obviously not too fancy there, but it does allow other stakeholders to see, that there was an intentional, change in dose or holding therapy or something of that sort. This particularly has been really helpful for oral oncolytics, particularly if patients, maybe it doesn't coincide with a clinic visit like it would with, or an infusion visit like it might with an IV therapy. So it's really just created a lot more transparency, I think, across the center about kind of what is the source of truth for that patient's current dose and plan. We do have what we call a prospective order review. So this has been in place across the center since about 2015. So about 7 years now, but essentially we have it configured in Epic that based on kind of the medication record level, all those orders are routed to an oncology pharmacist for review prior to leaving the Epic system. We do that really mainly from a safety perspective. So pharmacists are reviewing those orders in the same manner that they would, an order in the hospital, in clinic order, reviewing it for safety, dosing, monitoring, et cetera. It would contact you as the ordering provider, if there was anything identified on that review. We do track those interventions and just kind of, just to continually, monitor kind of the benefit of that process just from an overall safety perspective. So I think just important to be aware, from a provider perspective, when you're working directly with a pharmacist, alerting us that or keeping us kind of informed about kind of some of the steps in that oral oncolytic ordering process, if you are, ordering or reordering, is helpful just because, again, we'll get that in our queue and we can perform that review. We do have education standards, so it should be completed by or prior to cycle 1 for all these oral oncolytics. In general, pharmacists do lead that education where we're available across the center. So in clinic, inpatients, really it just helps to notify us if you have a patient that you're thinking about starting or going to start, just because we can kind of help, see the patient hopefully in person on that day, or whether it's, another means of communication, telephone, et cetera. But just helps us be kind of more proactive with some of those education efforts. We do have a portal on UConnect as well. So I have the link in here, but essentially there are we talked about the appendix to the policy. There's a diary available. There's some med-specific templates. There's a link out to patient education resources. So we actually utilize, these are third-party kind of maintained, but there's a group of about 4, 5 organizations that maintain these. They're pretty nice, and they kind of meet all the standards of what we should be talking to patients about. But you can search by med, pretty user friendly, and it will basically link directly to a PDF that you can generate and print out for patients. So it really goes over a lot of the things that probably you'd expect. And this is what pharmacists use for patients. But if you're ever needing to print out some education, this is readily available, which has been a really nice resource for us. And then monitoring is the last thing I'll speak to. So there is, best practices on continuing to monitor patients. So we, as best as kind of possible within our bandwidth for pharmacist resources do this. So for patients that are starting therapy, pharmacists will contact them generally about 7 days after, just to ensure they receive the medicine, they're taking it appropriately, screen for any early adverse effects. And then patients will be monitored kind of on an ongoing basis as well, kind of based on how they kind of do. If there's a lot of issues identified on kind of that 1 week call, we'll generally leave them on our outreach list and continue to follow up with them. If patients are doing really well, then we certainly would see them potentially in conjunction with you at your visits. And then at minimum, if patients are using our specialty pharmacy, we do talk to them at least every quarter. But we try to be kind of judicious and use our resources to the patients that have demonstrated either toxicity, non-adherence, that would probably most benefit from our service. So a lot of info there. Any questions about oral oncolytic policies, workflows? Any comments from those of you that have been here and worked through them?
Sometimes, this is Miriam. I do breast oncology. Sometimes it's hard because I feel like we don't use the treatment plan as often to release the med. So I think it sometimes gets lost, and it's only in the med list.
It's a great comment. Thanks, Miriam. I think that was kind of to some of my comments about the hybrid model. I do think that one of the challenges, to be transparent, has been, these plans are used across our dots, across the various centers. And I think each, to some extent, each group has had a little bit of different workflow until how they like to manage them. I think what we're hearing is that to mitigate that concern about keeping the plan up to date, that it might be most beneficial to actually try to continue to reorder in the plans. I think the best way to do that would try to be optimize refills, and then also, like, when providers want to standardly see patients, return. So we've had some discussion with that with the breast group, and we'll be folding that into some of those triennial review discussions. So I think we'll likely move in that direction. You'll probably still see some hybrid for a while, but I do think getting them kind of back into the plans to keep everyone using them, so we have labs monitoring, et cetera, is kind of the feedback we've gotten in the direction we're going to go.
Thanks.
So real briefly, just to wrap up here, just a couple of comments on specialty and PA. These are really, I think, over the years with this course, providers have felt just helpful, just pearls to be familiar with. So we have a specialty pharmacy here at UW Health. This is a picture of the physical building. It's located out on Deming Way in Middleton, so a little bit west of kind of the main campus here. This building facilities houses a lot of kind of ancillary pharmacy services, including our specialty pharmacy program. You can see, so it's kind of designed as a little bit more of a warehouse office building. There's no drive-through at this location. The main doors are kind of in the center of the picture there. So really, it was designed to serve as more of a mail-out facility. However, patients who do want to pick up medicines here can do so. It's just they have to kind of park out front where you can see that vehicle, and then the medicine will be brought to them. So that's definitely not a large percentage of our patients, but there is a process for it for patients that want or need to do that. Like I mentioned, mail orders preferred. So for patients on oral oncolytics, I'd say 99% of patients will use the free mail order service. We use a variety of vendors, primarily FedEx at this time, but patients that are in kind of the immediate area via FedEx or a courier service can have that medicine delivered really next day. For patients that are in the kind of more outlying areas, it could be one day on top of that. In terms of patient management services, so currently, like I kind of mentioned with some of the outreach, but we do have some integration with specialty and our kind of core oncology team. So, whether it be the education or the outreach for patients filling at specialty, we will have one of our pharmacists that's kind of involved with that process. So, because of that, for patients that insurance allows, certainly we prefer them to use our specialty pharmacy. We feel like we can provide a lot higher level of service and higher level of safety just because it's fully integrated and we have access to all the aspects of that patient's care. So we really appreciate when you partner with us, and for patients, unless their insurance really disallows, that they really take advantage of our specialty pharmacy service. As it relates to specialty, we have a prior authorization team within that group. So basically, all prior auth services are provided by our pharmacy department. We have a group that looks at medical benefits. So basically that's like in-clinic type of therapies, pharmacy benefits, that's take homes, including oral oncolytics. And then we have a medication assistance program as well. So basically for patients that, either have very poor coverage or are financially disadvantaged, we have a group that can help them access those services. This team's readily available via HealthLink. So basically you can open a telephone encounter and submit a prior auth request to them. There's a standard kind of phrase which we use, which helps you kind of provide them a lot of the information, and your clinic nurses can help you if you have not done that before, or you can ask them to help you, do those submissions, of course. They'll work up those requests, and then hopefully we get approvals. But again, there's kind of different routes this can go for patients that have higher out of pockets via that MAP program. We do have a repository program as well. Real briefly, this essentially is a state program that allows us to take back unused medications that's unadulterated from patients. So really big ones that we get a lot of donations on are like growth factors. We can get full bottles of certain oral oncolytics, but we could take them and then we could use them to other Wisconsin residents, kind of free of charge through some paperwork. So it's been a really nice program, particularly to help patients that want to donate. So the specifics of that program get a little bit in the weeds, but if you have patients asking about donations, just refer to your pharmacist and we can help you with that. Takeaway here is just, there's a variety of, or there's a kind of a bell curve of response times for prior auth. So, whether it's a commercial payer, government payer, I'm sure everyone's kind of familiar with that. So really, it's important to be proactive. So, if you're working in your practices and there's a therapy that you are thinking about, work with your team to get that submitted to our prior auth group so we can start working that up as quickly as possible. Our team is, willing, here to help and happy to help. And again, we hope to, or I think there's an advantage to, internalizing all those services, our specialty pharmacy as well. Certainly we have to send some patients or partner with other mail order pharmacies as patients' insurances require, but we try to, internalize it as much as possible as we're able under insurance. So with that, I think I'm about at time, so I'm happy to answer any last questions before we close.